Thanks, Pooja and Rohan, for having me in this nice meeting full of discussions and so many things to learn from each other. And I will be talking about, as you said, I'll be talking about importance of doing good refraction on your own for a successful practice. So, refraction is done for refractive error, and we all know that refractive error is a very common condition, one of the most common cause of blindness in both developed and developing countries. In developed countries, it's the commonest cause. In developing countries, it's after cataract, it's the second most common cause. Now, many times it goes undetected, particularly unilateral refractive error, wherein we also get to see a few patients who come to us now at the age of 25 or 30 when they recognized that in one eye they had less vision. So the importance of doing refraction is a lot, particularly in these cases. So the issues that we need to discuss is that why you should do it yourself, and what are the factors to be understood, and what are the advantages of handling these cases yourself. Now, doing it yourself doesn't necessarily mean that you do it by your own hand. You or your optometrist should be doing it in your office, wherein you are talking to the patient yourself so that you have a direct connect with the patient. You give a feeling that you are directly involved, and the patient feels that you are, that he or she is in a safe hand, in the hands of an experienced, or in the hands of a person who knows the subject and who is handling the case personally. And you try to make it as a part of routine examination. Now, doing refraction is very important because prevalence of refractive error is very high, and there's a large chunk of patients who report to ophthalmologists who have uncorrected refractive error. Now, just a couple of slides regarding what is the magnitude of problem of uncorrected refractive error. Now, worldwide, as I said, uncorrected refractive error is the leading cause of vision impairment, and it is the second leading cause of blindness in developing countries, which includes India, second only to cataract. And visual impairment and blindness caused by uncorrected refractive error in adults can have severe impact on social and economic well-being. And globally, there was one survey by this Frick, Kerry et al., and they found out that globally, economic loss due to lost productivity caused by uncorrected refractive error was huge. It was about 269 billion, and only due to uncorrected presbyopia, it was about 11 billion US dollars. So that is a huge amount. In children also, it is quite a major public health problem and requires concerted efforts. The prevalence, this was a prevalence study in our own country, and they found out that the prevalence of myopia, hyperopia, and astigmatism was 5.3%, 4%, and 5.4%, respectively. The RESC study, that is the refractive error study in children, reported population-based prevalence of presenting visual acuity of less than 20 by 40 in both eyes in urban and rural India as 7.4 and 4.9% respectively. And out of these who had less than 20 by 40 vision, out of these, 81% and 53% were because of refractive errors, different types of refractive errors in urban and rural areas. So more seen in urban, perhaps because it was more detected, and the patients, the individuals, the families could be contacted easily. Uncorrected refractive error is definitely a major health problem, and in India, about 10.2% adults have uncorrected refractive error, 30% of adults have uncorrected presbyopia, and a total of 550 million people, they need spectacles. So that's a huge number. So that is why you cannot leave this huge chunk of population. And there are certain points that you should remember while doing the refraction, if you're doing it yourself or you are getting it done by your own optometrist to take care, is that you should, first of all, start with the objective retinoscopy, and that you should sharpen. And of course, subjective refraction techniques should also be sharpened. Shouldn't take a lot of time in doing refraction, otherwise the patient gets frustrated. And the baseline visual acuities should be determined, and the pinhole visual acuity is something which gives you an idea whether this patient is having refractive error or not. If it is improving with pinhole, this means it's a refractive error. If it's not improving with pinhole, then it may be because of any macular pathology wherein pinhole reduces amount of light focusing onto the macula, and thereby it reduces the visual acuity with pinhole. The ideal size of pinhole is about 1.2 millimeters. If you are going more than that, then the blur circle will increase. And if you go lesser than that, then because of the refraction from the edges, again, it can cause reduction in visual acuity. Then what all things you need as far as for doing a good refraction? You need a good retinoscope. Well, preferably streak, because it's self-illuminating and it helps you in doing it at any place. A refraction chair with full unit, a space of about 6 meters, or if you can put a mirror, then 3 meters can also do, although it is not preferable, but yes, space crunch can be there, so you can use that. Understanding use of cycloplegic and understanding the use of cross cylinder and duochrome test in order to fine tune your refraction. So these are the things that you need as far as the investment for refraction is concerned. Then you have to understand the reflexes that you get by retinoscopy. Then subjective refraction like fogging you have to understand. And the goal of subjective refraction is to achieve a clear and comfortable visual acuity, binocular vision. And it is very essential to start with the objective refraction by retinoscopy, then go ahead and fine tune by subjective refraction, and then communicate with the patient in order to get the maximum satisfaction. Now, the question here is that why it is the need to do the refraction by yourself. The reason is that there's a large chunk of patients who have refractive error, as I have mentioned earlier in my talk. So you should not miss out on such a large population. And if you do it yourself, you won't lose the patient. You can counsel the patient and you can get a good patient satisfaction. And if you can do that, a good visual outcome with the refraction and a good counseling results in good patient satisfaction, and good patient satisfaction results in good revenue collection. So, so you can have a good revenue collection. And as just now, Dr. KP was telling that you should have your own spectacle outlet. If you have your own spectacle outlet, you can have a very good revenue collection just by prescribing glasses. So that is something which you should not lose. And a large proportion of such patients may be converted for refractive procedures. So that is further addition to the revenue collection. Now, why does a patient come to an ophthalmologist? The patient comes for getting good vision, right? And if you can provide by glasses, you can provide it by glasses or contact lens or by refractive procedure. Now, outlet also, then you can have a very good revenue collection. If you can convert the patient to contact lens, then it will further add to the revenue. The patient will buy contact lens, the patient will buy solutions, then patient will spend more time, will come for more follow-ups, and each follow-up will further generate revenue. And some of these patients can be converted to, refractive procedure or orthokeratology, or, then in such cases, you can further, add revenue to your existing, revenue generation. So that will be further very useful. And if you're providing all options at one place, then that is convenient for the patient. And the patient always likes to go to a place where you get a complete package. Why do you go to a mall? Because you have all the outlets there. So that is the reason why if the patient comes to you and he gets the refraction done also, and if he wants a refractive procedure, if that is also done, or contact lenses, if you can provide that also, and the patient can purchase from your place only, I mean, nothing like it. It's a lot of convenience for the patient, and that is what helps you in generating revenue. So in terms of return on investment, the ROI, I would say doing refraction at your own setup by yourself is very good. Why? Because it requires minimal investment, and it is mostly fixed investment. for surgeries, etc., you always have to, updating, you keep updating things, you keep buying more and more equipments, etc. But for refraction, you require a certain, minimal investment, for which, which may not be very difficult. And it is a sort of a fixed kind of an investment. You do it once, you can continue with that for very long. Now, and there's a recurring revenue, as I said earlier. Now, profitability of medical practice is dictated by the number of patients examined, the income generated per patient as determined by the intensity of services provided, and the cost associated with providing these services. Now, just go reverse. This statement is something which had come up in one of the newsletters, one of the editorials actually. And now just go from the reverse. Now, the cost associated with providing these services, if you're doing a refraction, there's minimal investment required. So the cost is less. Second point, income generated per patient as determined by intensity of services provided. The amount of services you do, the amount of counseling you do, you can generate a lot of income from that. And the third point is that the profitability is dictated by the number of patients examined. And you have a huge load of patients of refractive error. So the number of patients will be high if you handle these cases of refractive error yourself, if you provide a complete package at your place. Now, coming to the current scenario, the post-pandemic, during pandemic, the ophthalmic practice was hit very badly. And it is definitely the time to recover. So you can't leave any patient. Any patient that has come to you, you have to handle. And refractive error, which is the most common condition that comes to a patient, that comes to a doctor, has to be handled by yourself. So you have to do the refraction yourself and provide refractive correction by whatever means, by providing glasses from your outlet, by providing contact lens solutions, multi-purpose solutions from your own clinic, or by doing refractive procedure. So all these things can be done at one setup and can generate revenue. And there was a lot of talk about teleophthalmology and handling patients by teleophthalmology. But if a patient is having refractive error, teleophthalmology is not going to work in that. Teleophthalmology will not provide refractive correction. So because of COVID, there has been a lot of backlog of refractive errors, a lot of patients requiring refractive correction. And it is time that you attract these patients of refractive error to come to your clinic, to come to your setup. You provide all the facilities, you provide all sorts of corrections, and you generate revenue as per your will. So thank you very much for your patient listening. And, any questions or any suggestions from you all will be most welcome.
And Dr. Sinha, as you just mentioned that there is such a huge backlog of refractive error patients, especially again young kids who have got into online classes and are on the computer constantly for about 10 to 12 hours. So many asthenopia patients that come up. So what is your take on patients who come with asthenopia, sir? Do you prescribe glasses to say a 0.25 or a 0.5, or you say that you use them while you're on the laptop? What's your take on asthenopia patients which are on the rise because of COVID, sir?
See, asthenopia can be because of a couple of reasons. One is because of convergence insufficiency, which can, manifest when you are, using these screens for your online classes, etc. That is one. Number two, what we have noted in a few patients is that pseudomyopia develops in some of these patients. And pseudomyopia results in asthenopia. So if you prescribe for that pseudomyopia, or if you increase the amount of power in the glass, it is not going to solve the issue. So what we do many times, that if a child has come with a, say, increase in myopia, and if the parents give a history that the child is using a lot of having a lot of online classes, using the monitor from morning till evening, in that case, what we do is that we just try to ask the patient to sit there, wait for some time, put a +1 diopter lens, see how the eye rests, and allow the eye to rest. That is one thing. So that, and after that, you again record the visual acuity. So first you record the visual acuity, and because the child is accommodating quite a lot, so allow the patient to rest with that lens, and then again after 1 hour record the visual acuity. If it's improving, this means that it's a pseudomyopia. So that is one entity which we have to take care of, which you have to take care. And there's a rule for that we always say, that 20 that if the child has seen the monitor for 20 minutes, then the child should be advised to look at a distant object. I mean, 20 feet we say, but 20 feet is not always possible inside a room. So whatever maximum distant object that he can see for 20 seconds, and that will relax. So that is something that we do say, but many times, practically it is not possible. So, but obviously there's a thin line between this. You can't over prescribe also. If for pseudomyopia you don't prescribe, you would not like to do that. So then in that case, we have to counsel the parents quite a lot. The other group of asthenopia wherein we would like to look for the convergence insufficiency, and we would see if the child is having convergence insufficiency, that can also cause asthenopia because of the use of monitors and all that. So such children are advised convergence exercise, and a lot of kids, they do improve with that. One thing here, that there's a subset of patients who are having high astigmatism, and if you prescribe it right away, suppose they have come for the first time, and the person is having high astigmatism, and if you prescribe full, then such patients, they do have problems. So I guess in such patients, a good patient counseling, that we are not prescribing full astigmatism, and yes, of spherical equivalent can be done, and less astigmatism can be prescribed, and that can be counseled to him. And because at subsequent follow-up, once he comes, then you can add up. So that is one group of patients wherein genuinely you can have, even if you do everything right, access and everything is fine, but if you prescribe full astigmatism, in the first prescription, having high astigmatism, that is a group of patients wherein the tolerance is less.
What's your take in the current day scenario, whether to go for a big corporate or to go for someone local? Because they say that the big corporates, they take a big cut out of it. So what's your take on it, that, should you go for a local person who already has a store in the city, especially in small towns, or go for a corporate, big corporate?
If you want to start your own opticals, Rohan, why you want to go for a local optician, or why you want to go for a big corporate? You start your own. You can come. There are people like me, a lot of people like me, who started how to start an optical outlet in a clinic. Just talk to them. They'll advise you. It takes hardly some 3-4 days observation for you to be with them. They will teach you how to buy. Initially, you may find little difficulty to select frames, and there are thousands of vendors available in India. Once they know that someone is starting a clinic, within a couple of days only, there are 50 plus vendors come and show their frames. But since you are ophthalmologist, definitely our IQ level is much better than any other person. You yourself will know that, okay, these are the good frames. Always when you are starting the optical outlet, make sure that take from the company who can give you the exchange of frames. There are a lot of companies, what they do, once they give branded and all, they will tell that, okay, within 10 days I need the money. No, nothing like that. You tell them that you keep these all the frames, these are the quantity, take a minimum quantity. After 3 months, once they come with a new set of new models of frames, that time you have to tell them, see, these are the models, it's not moving, your job to exchange with that. There are 90% of the people, they exchange the frames. So I think if you start like this, I think you don't require any corporate, or you don't require any other nearby people. You yourself can start.
Right. And sir, what about patients, whom a spectacle number is not suiting, and they come back complaining to you? So how do you deal with such patients? Like, how do you counsel them that, this is what is the correct number? Even when you've done a repeat refraction, sometimes they say, no, that this is not suiting me. So how do you counsel those patients?
This is the one thing I think you have to be, if you are having your own optical shop, whatever they say also, there might be either problem with your refraction, first point, or second, there might be a problem with your optician, because you cannot have your own lens fitter initially. So you will be sending those frames to a nearby lens fitting shop. So even 5°, 10° of misalignment of these glasses, especially those are astigmatism, patient will come back to and start irritating, because you told that to buy from your shop, now I can. That time, even you should be ready to change them free of cost. That time you should not talk to them that I have done nicely, my nothing like that. Your job to change, it may go wasted also. You cannot think about that. So, but initial your practice, your job to give them the quality service. As a ophthalmologist, or if you're having optical outlet, even in the outlet also, they have to be very, very happy. So once you convince them, most of the things, what problem will have the early presbyopics, someone with a 42 years, these patients will come to you and they always tend to tell that, say, doctor, I'm wearing this glass. When I look at the ground, I could able to see upside down. So you yourself as a doctor, because your opticians or your the optical assistant, they cannot explain that well how best you can explain. So you can call them, you can tell them how to wear the glass, how to see the ground, make them to walk around in the room, make them comfortable, spend time for 2 to 3 minutes or 5 minutes. I think this problem should be through.
Dr. Mehta, sir, your comments.
This is a very, very dicey thing. You don't have to worry about it. Optical showroom, it definitely creates revenue for you. You have to have nice people who are humble over there. And as Dr. Kudlu says, no questions asked, change the glasses. With respect to a progressive glass, it's a love and love hate relationship. 70 to 75% will love it. 20% will just actually hate it. They start getting nausea and all that. It's not your fault. It was not a wrong number also. Third, a lot of people make a mistake that every headache which comes to your clinic is an eye problem and people prescribe a number. That is the job of a chashma wala. Don't do that. Explain to the patient, and I have to tell them that 95% of your headache is not because of the eyes. Only 5% is because of the eyes, and I'm going to take care of that. Remember, this is very important because their frustration, their migraine, their lack of sleep, their sinusitis is all on you. And just because they come to you, don't think that you have to prescribe glasses. So a good optical frame, showroom, no question, a must. Depends on what client you want. You have lower, medium, and higher. So you'll have to have all kinds of ranges, and you'll have to have trained people to do that. And you have to change glasses if patients are unhappy. You can't ask a question. Also remember refraction. The biggest problem is refraction. You give a glass number, even Bombay, every chashma wala refutes ke nahi wo number barobar nahi hai. They make them sit and give some number which is different. And we all know that you refract the same patient 3 times in 3 days, it will be a different number. The same patient, depending on his volume, or if a female has water retention, or how good they are, sugar or whatever. So anybody can dispute. So I have a lot of patients who come to me, ek chashma wale ne ye diya, dusre ne ye diya. Dono aisa galat, you tell me that. I said both are right at the right place. So it's just that you have to get figured out and give them some peace of mind. And it's a lot of counseling, chashma. Headache, different part of headache, but worth it if you have your team who can manage it. There is revenue to be made, and it's a very important part of your stream. In the beginning, it'll give you more than that. And as always, every footstep, your contact lens, your glasses, everything gets in more revenue than actually a routine patient.
So the crux is that you have to take the headache to counsel the patient so that the patient does not have headache.
Rajesh, all their headaches are your headaches, truly speaking. Their frustrations in life, most often than not, they are comfortable, but they have to crib somewhere, and the doctor is the best place where they want to come and crib. Aankh khatakta hai, laal hai, acha nahi hai, dukta hai. सर दर्द होता है, ये लेंस लगाया तभी से पैर में दर्द होता है. This is how we have to take it, part of our life, that journey. So that smile, keeping your patience, not losing your patience, that's about all. But the whole family, pediatric age group to geriatric age group, the beauty of ophthalmology is that you cater from almost 26 weeks to 126 years. That's the beauty. Male, female, pediatric, geriatric. So on your glasses note, headache, first disassociate the eye from the headache. Not every headache, and I believe me, in my practice, 90% of the headache is never because of the eyes.